welcome back. I am here again, to introduce to you and to give you a good information about general dentistry and about all the phases of dentistry. Those who did not watch me last time on my first episode, my name is Dr. Ofelia Villanueva. I graduated dentistry in the Philippines and also from Boston University, graduate of dentistry. I'm practicing for 18 years here now in Quincy. 18 years, a big time, I am presenting also the voice of the Academy of General Dentistry. As you know, Academy of General Dentistry is the voice of the general dentist. The Academy of General Dentistry, we are helping the community to know about the benefits of going to the dentist for general health of their mouth. Today, I would like to talk about the specialty which is for periodontics. And the guest for today is Dr. Paul Fugazzotto. He is a practicing dentist in Milton. He is also a visiting speaker in Harvard University. Let's welcome Dr. Paul Fugazzotto.
It's nice to see you.
Okay, and he will tell us all the good information about periodontics.
Thank you.
My first question to Dr. Paul Fugazzotto: what are the most exciting advances in periodontics over the last 2 decades?
Well, I've been practicing since 1981, so I've gotten to see what we did before and what we can do now. And I would say the most exciting things that have happened in the last 20 years are the ability, first of all, to understand periodontal problems more fully, to understand what it means to oral health, and to understand how periodontal disease and periodontal health are tied intimately to your overall health. There's a lot of relationship between periodontal disease and heart disease, or diabetes, or low birth weight babies. So there's no doubt that as we've understood this more, we've been able to render people's overall health better as well as their oral health. The second thing that's happened is with the advances we have now in helping patients to grow back damaged bone or to replace missing teeth with implants, we've been able to integrate these treatments into what we do every day and offer patients a lot more options. When I first began practicing, we assumed that certain teeth were going to be lost. There was nothing you could do about it. You would save the other teeth, you'd make partial plates people took in and out, and you would hope that they could function with them. Today, teeth that we used to take out, we don't take out anymore. We can treat them and actually help a patient to grow their own bone back around the teeth and save the teeth. Even when a tooth has to come out, you can grow the bone back the day the tooth comes out so you can replace it later. So there's really no need for anybody anymore to have loose partial plates or have something that's uncomfortable, and there's no need to take out a lot of teeth we used to save. So the biggest advances are helping patient overall health, helping patient dental health, and giving them options to maximize their comfort, their function, and their aesthetics.
As a general dentist, I always say, because we are the gatekeeper.
Absolutely.
We see the patient first,
You're the primary care
Yeah,
physician.
we are the primary. Yeah. And we see them,
Sure.
And when I check their teeth, as a general dentist, of course, we measure the gums.
Absolutely.
And we see that they have a bad gums, or gums is different from the periodontal. We know that. I don't know if people knows it, but the gum disease is different from periodontal disease. Usually, sometimes it's so hard to define to them about the gums in the bone. We refer it to you when there is a problem on the bone already, and you are talking about that now. If they have a periodontal disease, you cannot just pull the teeth, but you can save it. You mentioned about grafting, or did you say about the bone?
Right, to rebuild the bone, exactly.
Okay, people are not so aware about that yet, Me, in my office, if I tell them about bone grafting, they really don't know what is it. But maybe next time we'll tell them again, because I have another question here,
Well, you actually just mentioned 2 very interesting things. The first one was that that's why patients should be going to the general dentist regularly, is because if you catch it early enough, it's only inflammation of the gums. There's no bone loss. And you can just do some good cleaning and reverse it. So you're right, there's a big difference between some inflammation in the gums or gingivitis and periodontal disease. So if they go to you regularly, you can catch that and you can solve it before they ever have bigger problems.
Right, right.
Then when they get to the bone, if they do have to get to bone grafting, it's simple today. You don't take bone from other parts of the body. You don't do any of that. You basically give it some Novocaine, move the gum away, clean it out, put synthetic materials in, and you'll get the bone to grow back.
Yeah, you talk about synthetic material. Synthetic, you know, sometimes there's a synthetic, there is like, I don't know, like allograft or, you know, autograft. It's so hard to define it to the people.
Exactly.
I have to do it in a simple way.
Absolutely.
That we can graft it coming from your own body, or you can buy something.
And the point is, exactly, you put something in there that will stimulate your body to grow the bone back.
Yeah, yeah. So now, you know, I mean, you can give back the bone that we lost.
Exactly.
But isn't it how many percentage of going back in there? Are you talking about 50% or 100%?
It depends on when you catch it. If you catch it early enough and you catch it in the right shape, you can grow the bone back all the time. If it gets further along, you may have to replace some teeth.
All right, that's a good one, you know. Here, I have a second question.
Sure.
How does periodontal disease impact the general dentist?
How does it impact the general dentist?
Yes.
It impacts you on a number of levels. It impacts you because, number one, you've got patients, and you became a dentist to keep your patients healthy and to keep them in the best state of health you can, and they have to be healthy periodontally. It impacts because for you to do good restorative dentistry, for you to do good general dentistry, you've got to have periodontal health. For you to try and do things that in a bad periodontal disease is like putting a new roof on a house with a bad foundation. It's going to fail.
Yeah.
And more importantly, the whole key to success here is for the general dentist and the periodontist to work together to plan what's best for a given patient. And periodontics offers options to you as the general dentist that weren't there before. You know, you can, by saving certain teeth, you can build certain types of bridge work for patients and do other things. But the key is it gives you an environment to work, and it's going to work all the time.
Yeah.
And a lot of it you can treat in your office. You know, gingivitis, it should be treated by you. I mean, you can get in and catch it early and solve it.
Yeah, I always treat that.
Yeah,
you know, I give them, you know, if they have a gum inflammation, there is a new one, which I don't know if you believe on that. I believe in Peridex. I'm not, you know, marketing Peridex, you know, it's a chlorhexidine. And then if I see the patient really with periodontal disease, you know, I do a deep cleaning.
Right.
People don't know about deep cleaning. They said simple cleaning, deep cleaning. Deep cleaning is you come back maybe 2 times or 4 times. You know, it helps to put a Novocaine or anesthesia in order for the patient not to feel any pain. Just scrape the calculus or tartar. And then by the time after 3 months that I did it, I reevaluate them. Am I going to send to you or to other periodontists, or am I going to do it?
What I think you should be doing is what you sounds like you're doing. You go in, you clean out the bacteria, you get a patient brushing and flossing right, you see how much the gums are going to tighten up. If the bone loss is very early, or if there's only gingivitis, everything tightens up.
Right,
if you've got deeper pockets afterwards, then you have to be treated to repair them.
So meaning is going back to be tightened, that will help really to the gums.
Of
and
course.
then so that the bone, the bone will not be distracted.
Well, you've got to be, here's what it is. You know, as you know, in everybody's mouth is bacteria. It gets under your gums, separates the gum from the tooth, and it makes a pocket. If that pocket gets deeper than 3 millimeters, the patient can't clean it.
Right,
So
right.
they could clean forever, they won't get it. So the goal is to get rid of the pockets. If it's just swollen gums, when you clean it out and it tightens up, the pocket's gone.
Okay.
If after you clean things out, it's still probing 4, 5, 6 millimeters, we know there's bone loss there and that has to be repaired, or the disease comes back.
Yeah,
But the whole key is for them to get to their general dentist early.
Okay, that's very good. How about this one? What advances in periodontics are especially applicable to clinical practice?
The advances that I think are most applicable are, in general first, are making therapy simpler for patients and making it more predictable and making it less painful. That's in general. Specifically, what's applicable to clinical practice is the fact that you can go in and you can, as we said, grow bone around teeth to save them without any complexity. You don't take piece of bone from the chin or the hip or anything like that.
Is that no more? They're not doing that anymore?
Well, they are, but you don't have to.
Okay.
You can grow a finger's worth of bone for somebody without taking bone from other parts of the body.
Okay.
Somebody who's had dentures for years, you can grow back bone to either make the denture more comfortable or put implants in. So what's applicable with periodontics is 3 things. Okay. Number 1, you work together, you come up with treatment plans that are the best interest of the patient. Number 2, each step is made simpler. And number 3, each step is made less painful, as we'll talk about when we talk about further advances.
Okay, all right. Okay, my next question to you, Doctor. Can I say Dr. F?
You can say whatever you like.
Because my accent is really,
That's perfect.
you know, I'm a Filipina.
That's fine.
Not all Filipino are very good in accent.
That's fine.
Okay, so have implants significantly altered periodontal therapy?
Yes, they have altered patient care, period. When I trained, you used to go to great lengths to save a tooth that maybe wasn't that good a tooth because you needed something to hold this bridge work as long as you could. Then eventually, when those teeth went, patients would get either partial plates or dentures. You don't do that anymore today. The thing about implants is that implants done correctly in the proper amount of bone, they just work. They're predictable all the time. So that doesn't mean you stop doing things that work and just pull teeth out, but it means you don't keep teeth that are questionable anymore. If you're not sure, you can replace it with something that is very stable. You don't put a tooth through thousands and thousands of dollars worth of work to save if it's not that good a tooth, when you can take it out and put an implant in that's predictable. So, by the same token, though, you don't take out good teeth.
Okay.
You know, we're dentists saving teeth.
Yeah, are you saying that if the treatment for that tooth needs like endodontic, I'm sorry about root canal treatment, and then after that crown lengthening, then post-in-core, do you prefer to pull the teeth and do the implant?
I think
Are you saying that?
I think in my mouth,
okay,
and I really like me, in my mouth, if a tooth needed gum surgery and a root canal and a post and a crown, I would take that tooth out and do an implant because it's more predictable and actually less expensive. However, if the tooth just needed a root canal and a crown, I'd keep it. If the tooth just needed a simple gum procedure and a crown, I'd keep it. But once you add all these things to one tooth, you start to ask what you're doing for this patient and if you're helping them. Because they're going through more work, more expense, and they have a weaker situation afterwards. So I think that the challenge for us as clinical dentists is to figure out when to do what, not how to do it. We learn how to do it, to weigh when to do it and pick when to do each procedure.
I know, but the problem is that like the cost of the implant versus, you know, the one that you said about the root canal.
The cost of an implant and a crown.
Don't forget, Dr. Fugazzotto or Dr. F, that if the patients are depending on insurance, they do cover all the hard one. But then the easy one, which is the implant, that's the down, you know,
well, the truth,
fall.
if you think about it, the amount of cost to a patient for a gum surgery and a post and a root canal and a crown, when you do that, you're getting up to a level that's actually more expensive than an implant and a crown.
Oh, I see.
Not only that, but insurance, you only have so much a patient has in a year. So they're going to have and the insurance will cover the same amount toward the implant crown. You end up, and believe me, I spend all day trying to save teeth. But I always look at a tooth and say, what would I do if it was my tooth?
Okay.
You know.
All right. That's a good, you know, very good. What is the current thinking regarding bone grafting? You mentioned before about the bone grafting. You know, bone grafting, there is a synthetic. This is like coming from your own body. That other one is like the allograft. I don't know the people, but we don't have to tell so much because, you know, we can simplify,
Traditionally, what you did if you had to grow bone back is you took some bone from the chin or from the jaw or maybe from the hip and you transplanted it. And it works. And it works very well. But over the years, over the last 23, 24 years, we've started working with other techniques where if you're missing bone right here, you put the right calcium material in. You put a piece of Gore-Tex over it, which is like a Teflon mesh reinforced with metal to make a shelter. You put the gum over that, and the gum can't get in because of the Gore-Tex, and you grow back your bone. You know, I do a lot of, as you know, I do a lot of lecturing in the U.S. or in different parts of the world. And the thing I lecture about the most to surgeons is how to grow bone back without having to go to other parts of the body. This is not experimental. We've been doing it, although it's developed over the years, since '85, and we've published over 6,000 cases. That data from it, it works. And it works very predictably in the right situations. So all of a sudden, grafting is easy for a person. You can come in, and I don't have to take anything from other parts of your body. In an hour with some Novocaine, you can do a procedure to grow back this much bone. And it's easy, and it works in a healthy patient, you know. What
is the current thinking regarding, you know, the word sinus augmentation? You know, sinus, they said sinus, in here, sinus.
Right.
When you know, augmentation means adding, right? So can you define about that sinus augmentation?
Sure. What happens is when you lose your top back teeth, over time the sinus drops down, and we don't even know why that is. The sinus drops down. So now if you want to do implants back there, you don't have enough bone. And if you go to do the implant, you'll poke a hole in the sinus, which you don't want to do. So the technique that's been used for 20 years now, I started doing it in '88, and a couple of people had started before that, some long before that. The technique is to tease up the floor of the sinus gently, put some graft material in, and you grow back bone there. And it works, and it's very predictable. But it is a procedure you have to go through. It takes an hour or so, and you have to let it heal for a few months, and it's relatively invasive. Today, a lot of times, if you have just a little bone there, we can use new techniques where you actually tap the bone up. You tap it and lift the sinus just in that spot, and the bone grows very quickly, and it's very easy, and it's easier for the patient. So yes, you often have to grow bone back here to put implants in the top back area, but you can do it simpler now, in a much simpler way. I have a text we just published about a month ago. We have a whole chapter on just doing that because it works so well.
Yeah.
I did it in my mother's mouth, and I like my mother. You know,
so you're pushing the sinus up.
Just push it up, and
and then you're putting a little bone in there,
and it turns into
to the floor, and then you can do the implant safely.
Exactly.
Isn't it that there is a length of the implant that you put in the bone?
Well,
so if you have a very short, bone, then you can push it and make it long so that you can put
exactly, and you can put the implant in safely.
Safely,
That's the key.
So there's no problem of putting implant.
Exactly.
Yeah. Oh, that's a good one. How about what are the greatest challenges facing periodontics today?
There are challenges facing periodontics and facing periodontists. So let's look at both. The greatest challenge facing periodontics is to keep working to strive toward getting some of these newer materials and advances out there. Synthetic growth factors now, to be able to get bone to grow in ways we never dreamt of. But the biggest challenge is to keep educating the patients and making them realize how important it is and that it affects their whole health. That's the challenge.
Can I interrupt you for a sec?
Sure.
I want you to simplify the meaning of synthetic.
Sure. We have different types of things we can use. If it comes from either your body or it comes from other bodies, whether they're animal or human, that is not synthetic. Synthetic is something made that does not come from anybody's body at all, where you basically put the molecules together and make a growth factor.
Okay.
And it works in the body without having to have it donated from somebody else or take it from you.
Okay, all right.
And the real challenge we face today, and you see this as a general dentist every day, the challenge we face is to stay true to the reason we did this. And the reason we did this is to help people, not to argue with insurance companies or to worry about that kind of stuff. We're here to help people, and we can't lose fact of that goal. We can't lose fact of it as the government gets involved. The biggest challenge is for us to stay true to why we became what we became.
Yeah.
And that's to help people.
Right, to help people.
That's the challenge. And to work together to do it. That's the challenge.
Oh, okay. Dr. F, what do you see in the future of periodontics?
What I see in the future of periodontics is a few things. Some of the work being done with growth factors now is very impressive and is going to help us to help patients in ways we didn't believe in. For example, what we do right now is if you come into the office and we're going to do either significant bone regrowth or significant gum regrowth, before we do it, we draw a small amount of your blood here in the office. We spin it in a machine, and it separates your growth factors into a putty. You either mix that putty with the gum graft to rebuild gum so that it heals faster, or you mix it with the calcium to regrow bone, and it heals faster. This is something we didn't even dream about, taking your own growth factors and concentrating them just by drawing a little bit of blood. They use it with burn victims. The results are amazing. They use it with patients in institutions where they're going to have to do amputations. They can get things to heal. It's unbelievable. So
Really
that's one challenge. The second challenge is to keep perfecting the therapies we do, and this is what I see in the future. You know, we're talking about nanotechnology with implants, to make the molecules work even better, to get the implants to work even faster. When I started doing implants, if you were going to grow bone, you grew bone for 6 months, you put the implant in, waited 6 months, you did a tooth. Today, many times, you put the implant in, you grow the bone the same time. 8 weeks later, you put a tooth on it. and it's getting only faster.
Oh yeah, that's the modern one now, yeah.
Many times now.
Immediate loading, that's one. Immediate
exactly.
loading means like before you pull the teeth, on the time that you pull the teeth, then you put the implant,
and we do that.
And you put some bone in there in order to grow the bone in there.
And
it takes only 8 weeks.
And we put
8 weeks means 2 months.
Right, we put the implant in probably 95% of the time we take a tooth out, we put the implant in the same day. The same day. Sometimes you put an implant in intact bone, 3 weeks later you can put a permanent tooth on it. So these advances keep coming.
It's only 3 weeks.
If it's in intact bone.
Yeah, if it's intact, you reach the bone.
And you have to use an implant with a special surface to do that, an SL active surface, but it works. I belong to something called the International Team of Implantology, which is an international group sponsoring research. I was actually the first full-time clinician in it in the Northeast as a fellow. And, we sponsor research, and we've shown that in 3 weeks, you can go in with special surfaces and put the final tooth on the implant. So this is the future.
Wow.
Accelerating care, offering new care to patients, understanding growth factors. Everything's changing so dramatically, it's incredible.
Okay, so what do you see in the future of dentistry in general?
I see a challenge. What I see as the potential of the future of dentistry is the same thing that's happening in periodontics, is happening in orthodontics, is happening in general dentistry, which is these advances that make care easier for patients, us understanding what each other does more fully so that we can work together. That's the future where we can offer patients advantages and things we didn't even dream of. When I went to school, I didn't even dream of some of this stuff. I'm sure you didn't either.
No.
But we also have a challenge. And the challenge is that we have to stay true to it. We've got pressure from all sides. We've got pressure from insurance companies, from government, from these places that want to do discount things that's supposed to be better.
I know.
What we have to do is we have to spend our time with our patients and explain to them the needs and explain to them the advantages. And that's our challenge. If we do that, we can help people in ways that were never dreamt of, and it can get better and better. That's what I think.
That's really a good one.
But it's
and
the truth.
I have a question. The last one, how can the restorative dentist, that's me.
Yes, it is.
Right? Best impact the patient's periodontal health?
You can impact it on three points. Number one, of course, is diagnosis, seeing what's going on. Number two is explaining to the patient in detail.
Do I have to explain in detail?
I don't mean in detail about the techniques. I mean explaining what causes gum disease and what you can do to help.
Oh yeah, of course, that one. And about
Exactly.
implant, I normally say to the patient that I recommend the ideal treatment for their case is implant. That's easy to do that, and then referred it to you.
Right,
but then after that, you did the implant, then the next procedure, I tell them, I do as a restorative dentist.
And there's even
I
something
take the
before
impression,
that. But before even that, once you recognize it and refer it, then, as you know, we sit and we talk about it, and so we both give our perspectives and we do what's best for the patient. We figure it out together. Some patients you handle this way, some patients you treat this way, and we figure it out together. Then I do my part, you do your part, with us always communicating, and they get the best result. So that's the key. It's diagnosis, it's explaining to the patient, it's knowing when to treat it in your office, like we talked about, the early things, when to refer it, and then communicating so we do it right together. That's the key, because what we're here for is patient health. That's it.
Yeah, I would like the public to know that if they have a missing teeth, like for a long, long time, that is a missing tooth, and nothing happening on the grinding of the food, still the function is there, do you still recommend them to have the teeth?
I do, because honestly, the bone keeps shrinking otherwise.
Okay.
As the bone keeps shrinking, I saw a patient just a few days ago, very nice woman in her 80s. Her bone is so paper thin here that her jaw is probably going to fracture. And she's got to have some plates put in because she just was chewing on dentures that were bouncing up and down. And over time, the bone just disappeared. It was probably 2 millimeters thick. So honestly, she's going to have some plates put in just to protect the jaw.
So you still recommend them
Absolutely.
to do the implant?
They've got to have
But those teeth that being like moved or migrated, and I know that the orthodontists play role on that
Absolutely.
before you do any implant.
Absolutely.
They have to put back in a proper position,
Absolutely.
the teeth in order for you to have a place for implant.
Absolutely. And one of the dangers is you take out a tooth, these teeth start to tilt, the top teeth start to drop down, the bite starts to collapse, you end up with TMJ problems, you end up with major problems that could have been solved easily.
Right, the TMJ, yes, that's why some
problem.
people, yeah, they are asking about like, what is the cost of mine? You know, I have a TMJ now, and me as a general dentist, you know, I don't go into that therapy, and I tell them, yes, you have a problem. Sometimes you have a bruxism problem, or that's a thing about
right.
the
Sometimes
losing,
you have a grinding problem,
losing the
bruxism.
bite, which is losing
right.
the occlusion.
Right,
Occlusions,
your bite starts to collapse.
right, it collapsing bites.
Right.
So now, you know, refer back to the orthodontist and refer to you in order to return.
To reconstruct it.
Yeah, and the last question I said, that's my last,
That's
but this is
okay.
another one. I know you are a specialist, you know, in periodontics, and you do implant. How about those general dentists who's doing also an implant?
Here's what I would say. Well, I would say the following, and there are a couple of levels of this. The first one is that everything goes down to diagnosis. And if you don't have a right diagnosis, it's dangerous. Somebody asks me sometimes, what is the simple implant? The simple implant is one where nothing goes wrong. You know, and you've got to not just be able to technically do it, you've got to be able to handle the problems that can arise. If an emergency comes up, you've got to be able to deal with it to the best advantage to the patient. And what I would say is that, in my opinion, I don't do restorative dentistry because I don't do it as well as you. I know I don't. And for me to go and take a couple of courses and do it, I will never do it as well as you. And we teach a lot of courses upstairs in our education center to surgeons from around the world, and some restorative people come. And if you're going to do surgery, you've got to get a certain level of surgical training, not just to protect yourself, of course that's there, but to protect the patient. Because, you know, when a person
Surgical training.
You know, there's an important thing. When a patient comes to us, they trust us. You know, they give us their bodies and they trust us. And we have to be able to do this correctly. You know, I can't do the restorative as well as you. I'm not doing it. If somebody, I had a general dentist come in who'd had about 300 hours of surgical training over the last 10 years, and he basically had gone to a surgical program. And that's one thing. To take a weekend course and do it, when something goes wrong, it's a very dangerous thing for the patient and for the dentist.
All right.
But it's dangerous for the patient, which is what really matters.
So meaning, you know, when you go to have an implant, you have to make sure that you're going to go to a dentist who has a lot of training, you know, yeah, on that field of implantology.
Absolutely.
But
just like if I'm going to go to somebody to put a crown in, I want to know that they've done a lot of crowns and they know how to do it. You know, I don't want to be your first crown, your second crown, your 10th crown.
Right,
I don't want to do that.
You know, Dr. Fugazzotto, I know you're so tired now. You talk so much for that. You know, I ask you so much, and you know, but this one is helping people, especially in Quincy. I live in Quincy, and I practice general dentistry, as I said, in Quincy for 18 years. And
just
Dr.
a baby.
Yeah. No, I think I'm getting old now, but you know, I said I have 7 years to go and I'm done, and I hope my kids will be a dentist, and I want them to get a periodont, you know, to be a specialist in periodontics, you know, to help the people in order to maintain their oral health, you know. I thank you so much, Dr. Fugazzotto. It's really a great pleasure, you know, and thank you for letting us to be on your office.
Of course.
And before we leave, I would like, do you think you can show your office?
Sure.
You know, Dr. Fugazzotto is practicing for how many years?
1981, 28 years.
1981.
Since I was 5.
Oh, my goodness.
This is a CAT scan. Okay, we've had it for about 3 years. You sit in the chair, and in 27 seconds, it takes a CAT scan of your head. Gives you all the information you would get from a CAT scan of your head and neck at a hospital. So we do it right here. Literally within 3 minutes of sitting in the chair, we can go sit here and go over the CAT scan with you.
Dr. F, CAT scan, isn't it that's necessary, you know, before you do any implant to
I think it is in a lot of
CAT
cases, especially in the lower posterior where there's a nerve. You really want to do that to do things safely for patients. And you know, it's something we got 3 years ago because we felt it was necessary to do the care correctly for people. This is a conference center that we use. It's wired with cameras and audio to the surgical rooms downstairs. And we give courses throughout the year to surgeons from the US and from different countries, teaching them how to do some of the more advanced techniques. We had groups here in the last year from Spain, Italy, Australia. We've had people from England, Germany, and from throughout the US. So this room is used for that. It's our lecture room, and they can watch on the screen the surgery going on downstairs. So basically, we use models, we use the lectures material, they watch the live surgeries. These are real human skulls, and we use them to describe the different techniques and what people can do. And this is the hands-on laboratory we use, because after they watch the surgeries on camera, and I explain it to them with slides, then they come in here and they practice on models, practice the techniques with us, with myself and other faculty I bring in watching them to make sure they're doing it correctly.
I hope next time you will see me again, and I hope I can give you another topics regarding dentistry. And I'm planning to have an oral surgeon, sorry about that, an oral surgeon to be our next guest. Thank you so much and have a nice day.